Okay, hello guys. So, good day to everyone. So, for today, we are going to discuss a new topic for MS, which is the perioperative nursing. So, if you want to specialize in being an OR nurse, operating room nurse, you need to know the concepts regarding perioperative nursing. And here's a lesson regarding this concept. So perioperative nursing. This is used to describe the nursing care provided in the total surgical experience of the patient, and it consists of three parts. So the perioperative nursing is divided further into three. Its scope are the following. We have a preoperative phase, so that is before the stage before the patient will undergo surgery. Intraoperative, that is the stage where the patient is currently on or inside the operating room. He or she is being operated on. And lastly, the post-operative stage. So that is the period after the patient has been operated on. So the definition for preoperative phase, this extends from the time that the client is admitted to the surgical unit. So we have the surgery department at the hospital. So once he or she is admitted there, that's where the preoperative phase starts until the time that he or she is prepared for surgical procedure. So when the patient now is being prepped for surgery, until he is transported into the OR or the operating room. That is our preoperative phase. For the intraoperative phase, this extends from the time that the client is admitted in the OR. So the client now is inside the operating room to the time of the administration of anesthesia and the surgical procedure is done until he or she is transported now to the recovery room or the PACU. So that is the intraoperative phase. So time the client is admitted to the OR, anesthesia is done, surgery is done until he is transported to the RR. And the post-operative phase, this extends from the time that the client is admitted to the recovery room to the time he's transported back into the surgical unit, so into the surgery department of the hospital, until the patient is just discharged from the hospital with succeeding follow-up care done on the patient. So that is the post-operative phase. Now, there are four major types of pathologic process requiring surgical interventions. Remember this mnemonic, OPET. OPET. These are categories that will require the patient to undergo a surgery. OPET. The first one is obstruction. There may be an obstruction inside the patient's organs, such as impairment to the flow of vital fluid such as blood, urine, CSF, or even bile. So there's something wrong with regards to the blood vessels, to the urinary system, the digestive system, and the other structures of the body. There is also perforation. Letter P, perforation, there is a rupture of an organ. Let's say, for example, ruptured appendix, ruptured stomach due to ulcer, or ruptured intestine because of intussusception, and others. So this can happen. There can be perforations inside that needs to be operated on, or any aneurysm that has ruptured that is under perforation. Next is erosion, wearing off of a surface or membrane. So let's say, for example, you have burns on your skin. That is a perforation. Or you have extensive abrasive wound on the skin. That is an erosion. So that's letter E. And lastly, for letter T, tumors, abnormal new growths, cancerous growths. But it can either be benign or malignant. So those are the tumors that needs to be removed from our patient. So now we need to identify the types of pathologic processes that will require surgery. An example of obstruction would be hydrocephalus because there's excessive CSF building up in the patient's cranium due to an obstruction in the brain of the patient. The CSF needs to be reabsorbed, but that doesn't happen due to congenital obstruction. Burns are types of erosion. I've mentioned that earlier. Benign prostatic hyperplasia, that is under tumor, of course. So that's one example for tumor. Obstruction, we have cholelithiasis in intussusception. Cholelithiasis because there is bile stones blocking the passageway for bile in the hepatobiliary tree. Intussusception, this is where the intestines telescope with each other. So if they telescope within each other, this can cause obstruction of the flow of food and fecal matter if the large intestines are involved. And for ruptured aneurysm, that is a great example of perforation. So I've mentioned that earlier as well. Now, we go to the classification of surgical procedures. Now we go first to according to the purpose. First is diagnostic. Of course, from the word itself, some of the surgeries are done in order to diagnose the condition of the patient. Like, for example, so this is to establish the presence of a disease condition. Example is by doing biopsy. So if they operated on a patient and took samples of the breast tissue in order to detect for the presence of breast cancer, that is under diagnostic. We also have exploratory to determine the extent of disease condition. Let's say, for example, the patient has ruptured appendix. The doctors now need to do exploratory laparotomy, explore lap, in order to determine the extent of the disease. Because aside from doing explore lap, they need to clean the bowel organs since they're sterile, and once the appendix ruptures, bacteria is going to go out of it and cause infection in the peritoneum. So that's exploratory. Next is curative. To treat the disease condition. This is mainly what surgeries do to cure the disease of a patient. And we have several types under curative. We have the first one, ablative. When we talk about ablative surgery, this is the removal of an organ, like the surgical procedures ending in ectomy, like appendectomy, oophorectomy, salpingectomy, hysterectomy. These are examples of ablative surgery. Once you hear the suffix ectomy, that is ablative. It's removal of an organ. Next would be constructive. So when we say constructive, it's repair of congenitally defective organ or repair of a diseased organ. You will always encounter suffixes under constructive surgery ending in such as the following: PASTI, RAFI, or PEXI. So PLASTI, RAFI, or PEXI. Like for example, arthroplasty. So that's a repair of a joint. Or Episciography, repair of the perineum. So those are examples of constructive surgery. Ending any surgical procedure that ends in plasty, raphy, or pexy. And for reconstructive, this is repair of a damaged organ. So they need to repair. Let's say, for example, the skin is damaged. One type of reconstructive surgery would be debridement. Debridement. For those who have burns, for example, abrasive skin injuries, they need to do reconstructive surgery. Or those who will undergo skin transplants, for example, that is still under reconstructive surgery. Or those who are going to undergo surgical anastomosis. Again, that is under reconstructive surgery. Next, palliative. This is to relieve distressing signs and symptoms, but it does not necessarily cure the disease. We've mentioned a few of these surgeries during pain management. When they are going to operate on the patient's spine or even the brainstem in order to remove the chronic pain that the patient is feeling. So that is palliative. Palliative. It did not cure the disease, but it will help relieve the signs and symptoms. So we need to identify according to the purpose of surgery. Pap smear is an example of a diagnostic procedure. Tonsillectomy, ectomy, so removal. Nephrocapsulectomy, so both of these are ablative under curative. Osteoplasty, so repair of a bone, that is constructive. Perineoplasty, curative, reconstructive, that's repair. Trachealorrhaphy, so that is curative, constructive. And skin grafting, curative, reconstructive, that like what I've mentioned earlier. If you have burns or abrasive skin injuries. Now we go to types of surgery according to urgency. Classification. First one, emergent. So for emergent type of surgery, this patient now will require immediate attention, immediate surgery, immediate operation, because the patient is currently having a life-threatening condition. And the indication for surgery here is without delay. So, for example, if you have observed in the surgery ward or surgery department, there is a large either blackboard or whiteboard there wherein they place the name of the patient, the doctor is going to operate on it, the time when the surgery is going to be done. So it's scheduled there for OR1, OR2, OR3, and so on. But if a patient comes into the ER suffering either from the following: severe bleeding, gunshot stab wounds, or fractured skull due to falls, for example, they need to reschedule the following surgeries posted there. Because who is going to be needing it more? Those patients who have emergent type of surgery. They need to do an operation immediately on these patients, or else they are going to die. So take note, let's say for example, the patient has ruptured aortic aneurysm, there will be severe internal bleeding there. The doctors need to operate on that patient immediately. So the other scheduled patients, probably they have urgent or imperative, required or elective surgery, they are rescheduled. Okay? Next, we have urgent or imperative. The patient here requires prompt attention. Not immediate, but it should be done around 24 to 30 hours once admitted into the hospital. Let's say, for example, kidney or ureteral stones. Also, um, if the patient is suffering from cholecystitis or cholelithiasis, they need to be operated on not immediately, but urgently or imperatively within the next 24 to 30 hours. Next one is required surgery. Patient needs to have surgery, but the planning of this is within the next few weeks or months. So this one, unlike the first two, emergent and urgent, it can be life-threatening, but for required, it's not really life-threatening. Let's say, for example, if the patient has a cataract if on his eyes, that needs to be planned. It needs to be scheduled within the next few weeks or months. Or patients who have thyroid disorders, goiter, they need to schedule this within the next few weeks or months. So it's really not that urgent. Next, we have elective. Patient should have a surgery. And this one, it really does, if the patient is not operated on, it really is not catastrophic for the patient. It really cannot kill the patient, since these types of surgery electives such as vaginal repair, repair of a scar, what else? Repair of a joint, for example, these are elective types of surgery. It's not really life-threatening. And lastly, optional. So it's based on the patient's decision. It's personal preference now. And who are having these kinds of surgeries? We have celebrities or people who really do not have that much self-esteem, self-confidence with their own bodies. They are not contented with what they have with their bodies. That's why some of them, they undergo cosmetic surgery that is under optional. So if you want to have your lips be like Angelina Jolie, for example, or if you want to have your flat chests to have bigger breasts, that would be under cosmetic surgery. It's optional. You really do not need that kind of surgery, unlike the previous four that I have mentioned. Now we go to according to degree of risk. Major surgery. This is a high risk and greater risk for infection. And usually for major surgeries, they are extensive, they are or prolonged. So you will be spending with the surgeon, if you are an operating room nurse, a scrub nurse, you're going to be spending sometimes your whole shift or even more than that, assisting the surgeon during that type of surgery. And there will be large amount of blood loss. So you are going to prepare blood products during this kind of surgery. And vital organs may be handled or removed in major surgery, such as brain surgery or open heart surgeries, abdominal surgeries. These are examples of major surgery. Minor, they're not really prolonged. It can be done in less than an hour. And it leads to few serious complications, and it involves lesser risks. And I believe you're collecting 5 major and 5 minor surgeries for your cases. So that is according to the degree of risk. Okay, next, ambulatory surgery or same-day surgery or outpatient surgery. The advantages of this is it reduces length of hospital stay and cuts costs. Of course, if you are a patient who's going to do ambulatory surgery, it really doesn't cost that much because you're not going to stay at the hospital here. It also reduces stress for the patient. There are less incidences of hospital-acquired infections, so you will not be exposed to various nosocomial infections at the hospital. There's less time lost from work by the patient, minimal disruption on the patient's activities and family life, because this can be done in a single day and the patient sent home afterwards. Disadvantages: there's less time to assess the patient and perform preoperative teaching, less time to establish rapport as well, because some patients can have anxiety with regards to this outpatient type of surgery. And there's less opportunity to assess for late post-operative complication. And what are these examples of ambulatory surgery? Example would be teeth extraction. We really do not assist with that since dentists are the ones doing it. We have circumcision. That's very, very common here in the Philippines. Vasectomy can also be done under ambulatory surgery. Cyst removal, especially if it's not that big or if it's growing on the skin, that can be done in ambulatory surgery, or bilateral tubal ligation, BTL. So both BTL and vasectomy, which is a permanent form of contraception, both of them are the only surgical forms as well. They are done in an outpatient department. Now we go to the surgical risks of that can pose a risk either intra or post-operatively on the patient. First, we have obesity. Obese patients are at risk for, or there's a surgical risk for them during post-op because of the increased fat or adipose tissue in their skin. There will be decreased blood flow to the skin that will help heal the wound or the cut that has been made. And obese people also are, at the same time, they may have a coexisting disease such as diabetes mellitus. And remember, past people who have diabetes, that's one of the surgical risks as well, presence of a disease. They will also have a hard time have a hard time with wound healing, since their blood is hyperglycemic. This can also pose a risk for post-op infection because the sugar in the blood can be a source for bacterial growth. Also, poor nutrition is a surgical risk, especially if the patient is malnourished. So how is the patient going to heal the wound post-operatively if they are malnourished? Remember, we need protein for the repair of tissues after the patient has undergone surgery. Those who have fluid and electrolyte imbalance as well. This can pose a risk for surgery. So if you have, or if you are dehydrated, for example, of course, how is wound healing going to occur if you have dehydration? So that can pose a risk. Age, of course, the older the person is, the more that the person is at risk for post-op complications. Presence of a coexisting disease such as cardiovascular disease, those who have hypertension, for example, or those who have respiratory disease, they can have post-op complications, or those who have DM as well. Or concurrent or prior pharmacotherapy. So if they are taking in drugs that can interfere with the wound healing later on, this can be a surgical risk, especially if the patient has a cardiovascular disease and then they are taking anticoagulants such as heparin or Coumadin. This can be a problem with wound healing later. Other factors: the nature of the condition, location of the condition as well, magnitude and urgency of the surgery, mental attitude of the patient can be a surgical risk, especially if the patient is uncooperative, and the caliber of the healthcare team. So the healthcare team should be very, very trained, most especially the surgeons, to do those types of surgeries that they are going to do on their patients. And with regards to the condition, of course, the if the patient, let's say, has tumors of the brain, that can be a surgical risk, because if the neurosurgeon is going to operate on that patient who has a brain tumor, if they made a mistake, for example, with the cutting of the tumor, they can cut certain blood vessels that are supplying the brain and can cause a stroke to the patient. So the nature of the condition is also a problem with regards to surgery. Okay, next we have the preoperative phase. So we're now in the preoperative phase of our periop nursing. The goals of the pre-op would be to assess, you're going to assess and correct the physiologic and psychologic problems that may increase surgical risks. So if the patient has problems, cardiovascular problems, or they are taking anticoagulants, if they're going to undergo surgery, we need to manage them first. They need to stop taking anticoagulants, or if they are experiencing hypertension, we need to manage hypertension first. Or if they are very anxious with regards to their surgery and they are uncooperative, we need to explain more why the patient needs this surgery. And we are going to give the person and others or significant others the complete learning or teaching guidelines regarding surgery. So as nurses, we need to know what type of surgery is going to be done on the patient, how is it done, or how the surgeon is going to do it, and we need to educate the patient and their family with regards to that type of surgery that they will undergo, including the advantages or disadvantages or risks about that type of surgery. And we need to instruct and demonstrate exercises that will benefit the person during the post-op period. So it's range of motion exercises are example of exercises that we can teach to the patient. And to plan for discharge and any other projected changes in the lifestyle due to the surgery. So physiologic assessment of the client who will undergo the surgery, we need to assess for the presence of pain. Assess also the patient's nutritional and fluid and electrolyte balance, because if the patient is malnourished, they will have a hard time with wound healing after the surgery has been done. Also, the cardiovascular and pulmonary function. They should undergo the so-called CP clearance prior to surgery, because if they are not cleared with their cardiopulmonary function, they are not allowed to be operated on. They should be cleared with this, the cardiopulmonary function. You should obtain that from a physician, the CP clearance, or else the patient cannot be operated on. Assess the renal function as well. We need to do that. This is with regards to the fluid and electrolyte balance. If they can excrete the waste materials and fluids. GI and liver function should also be tested prior to the surgery, most likely if the patient will undergo abdominal surgery. Endocrine function. Check if the patient's blood sugar levels are high, because this can be a problem post-operatively with regards to wound healing again. Like what I've mentioned, if they have hyperglycemia, this would be or the sugar in the blood would be a medium for growth of microorganisms that may be present in the incision site. Neurologic function is also important. So we need to know if the patient is conscious enough with regards to what the type of surgeries he or she is going to have. We need to check their Glasgow Coma scale as well. Hematologic functions should also be checked, because how are they going to heal their wound if they have bleeding problems? So they're going to check the prothrombin, the partial thromboplastin time, in order to assess the patient's capability of blood clotting. Use of medications, because like what I've mentioned earlier, there are certain medications that will interfere with wound healing, such as taking anticoagulants like heparin or Coumadin. And the presence of trauma and infection as well, because if they have a coexisting infection, this can be a problem once the patient is already in the post-op phase, because again, it can further infect the patient's wound. Now we go to the routine pre-op screening tests. These are the needed or the routinary tests that are done on the patient in order to assess if they are going to be operated on or not. So CBC will be checked, the count of the RBCs, the hemoglobin, hematocrit, in order to determine the oxygen carrying capacity of the blood. WBCs as well, to check if they have good immune function. Blood grouping and cross-matching as well is done, most especially if the patient is going to have extensive surgeries, major surgeries, because just in case the patient will, or the physician is going to give blood products on the patient through blood transfusion, we need to do blood grouping and cross-matching for this. Serum electrolytes are also needed to assess for the fluid and electrolyte status of the patient. And I've already mentioned PT and PTT earlier, to assess if the patient is capable of healing their wound or blood clots. FBS is also needed, because there are certain patients who do not know that they are already experiencing hyperglycemia. They don't know that they have DM. Some have undiagnosed DM. So we need to check that just in case they have hyperglycemia. If they have hyperglycemia, that needs to be treated first, because this can affect wound healing later. BUN and creatinine also will be assessed to evaluate the renal function. ALT, AST, LDH, and bilirubin. These are tests that will evaluate the liver function, just in case the patient will undergo any types of liver surgery. Serum albumin and total protein will be checked to evaluate the nutritional status, because remember, protein is needed in wound healing. Urinalysis as well will be done to determine the urine composition. Chest X-ray, this will evaluate the respiratory status and the heart size. This is needed during the CP clearance of the patient, the chest X-ray, including ECG as well, if they have a pre-existing cardiac problem. So these two are needed to clear the patient with regards to their cardiopulmonary status. Now we go to the psychosocial assessment in here. One of our nursing roles in a patient who will undergo surgery is to allay or alleviate any fear that the patient will have prior to the surgery. Remember, all patients who will undergo a major surgery would be having moderate to severe anxiety, most especially if they know about their condition, if they know about the risks of the surgery that they will be undergoing later on. We need to allay these fears, these anxiety of the patient. So fear of the unknown is there, or anxiety, fear of the anesthesia, fear of pain, most especially if the surgery is just a minor surgery. They will be able to feel it somehow, the pain. And of course, the post-op pain that the patient is going to feel. They are afraid of that as well. Fear of death, because some patients, if they know how grave their condition is, they know about the risks of the surgery. Sometimes they might fear of dying on the operating table. And also fear of disturbance on body image or body image disturbance. Of course, if the patient is going to undergo, let's say, for example, amputation, of course, they are going to feel that disturbance of body image. Or breast removal. If the patient has breast cancer, for example, they will experience these things. And worries such as loss of finances, because surgeries can be expensive, their employment as well, their social and family roles. So we need to allay these things from the patient. We need to provide psychosocial support for the patient. If the patient wants to cry before the surgery, let them cry. If the patient wants to talk about their fears, let them talk. These things are normal prior to the patient's surgery. So what are the manifestations of fear that you can see on the patient? Anxiousness. So if the patient is jittery, you can see that on the patient. The patient is bewildered. There's anger. They are uncooperative, for example. And the tendency to exaggerate. They will tell you that, what if I'm going to die on the operating table? What if the doctor is going to make a mistake? And other things that they overthink about. So they can sometimes tell you these things. Or they can be sad, they can be evasive, they don't want to talk about their condition or the surgery, or they are tearful or clingy. These are manifestations of fears. The inability to concentrate as well, or having a short attention span, or failure to carry out simple directions. So you're teaching the client how to do simple range of motion exercises and they cannot follow the instructions that you have been teaching them. These are signs that the patient is anxious about the surgery, or they are dazed as well. You can see that the patient is staring out into the open. So these are manifestations of fears. So in order to minimize anxiety, one of our nursing interventions is explore the client's feelings. We need to talk to them about it. Tell me how you feel about the surgery that you are going to have. Or allow the patient to speak openly and give accurate information regarding the surgery. So you need to let the patient know how the surgery is going to be done. In order, that is also their right. They need to know how it is done. And give empathetic support. By showing empathetic support, I know it's hard to be in your shoes right now, but you need to do this surgery. You need to overcome your fears and so on. And consider the person's religious preference. If they need to have a priest or a minister visit them prior to the surgery, just allow them to do so, because this is also one way of allaying the anxiety of the patient, for them to seek for any religious arrangements with their priest or their ministers. Informed consent. This is one of the important things that we need to secure during or pre-operatively. Our role as a nurse is to secure the informed consent on the patient's chart. I repeat, the role of the nurse regarding informed consent is to secure the informed consent on the patient's chart. Who is going to let the patient sign the informed consent? It is not us, but the surgeon. It is the surgeon who is going, or the surgeon who is going to do the operation on the patient should be the one to let the patient sign this. So this is an example of an informed consent. So the patient or any authorized person should be the one to sign this. together with a witness. So purpose of this is to understand that the client understands the nature of the treatment, including the potential complications and disfigurement. So this is explained by the doctor. It's the doctor who's going to do this. And also the purpose is to indicate that the client's decision was made without pressure. So there's no pressure done. We didn't insist that the surgery is going to be done on that patient, and to protect the client against unauthorized procedure as well, and to protect the surgeon and hospital against legal action by a client who claims that an unauthorized procedure was performed. So this is also about legal matters. So we need to obtain that informed consent from the patient. Circumstances requiring consent. Any surgical procedure where scalpels, scissors, sutures, hemostats, or electrocoagulation may be used. So we need to obtain the informed consent here. Or entrance into any body cavity. So anything that's going to be inserted. There are certain surgical minor surgical procedures, diagnostic procedures, wherein we insert or doctors insert things into the patient's body. Like, for example, pap smear. We also have transesophageal echocardiography. We have, what else? We have cardiac catheterization. These are examples of anything that will enter the patient's body. Minor procedures. Radiologic procedures as well, particularly if a contrast material is required, such as those angiography, the several types of angiography, or general anesthesia, local infiltration, and regional block is going to be done. This needs informed consent as well. So the essential element of informed consent are the following. First is the diagnosis and explanation of the condition. So let's say, for example, the patient has cancer, it should be explained there. And a fair explanation of the procedure that is going to be done, whether it's an ectomy, a repair, and whatsoever. A description of alternative treatment or procedure, if available, and a description of the benefits to be expected. So once the tumor, for example, is removed, other treatments will be available, such as radiation therapy, chemotherapy, in order to treat the cancer that you have. So if the tumor is removed, this will further prevent the proliferation of cancer in the patient. And the prognosis if the recommended care procedure is refused. So for example, they've refused. You need to tell them the consequences of them not having the surgery. So for example, the patient has, let's say, a tumor growing on the kidney. Let's say that is stage 3, or no, stage 2. And if they refuse to be operated on, tell them that it can proceed to stage 3 and it can metastasize. So we need to inform them of those consequences if they refuse the surgical procedure. Requisites for validity of the informed consent. So to declare that the patient's informed consent is valid, the written permission is best and legally accepted. So written, they need to write it down or write their name, sign it as well. Signatures obtained with the client's complete understanding of what to occur. And adults, of course, will sign their own operative permit and should be obtained, of course, before the patient is going to be sedated with an anesthesia. But for minors, parents or someone standing in their behalf gives the consent. But for a married emancipated minor, parental consent is not needed, but spousal consent is accepted here. So there. So if emancipated minor, parental consent not needed, spousal consent is accepted. For mentally ill or unconscious patient, the consent must be taken from the parents or any legal guardian. So for example, the patient is mentally ill and is already an adult. You can obtain the informed consent from the patient or parents, from the spouse or any immediate family member that the patient has, especially if the patient is unconscious. Let's say, for example, the patient fell on his head and became unconscious afterwards and needs to be operated on because there is a blood clot inside the patient's cranium. So who's going to sign the informed consent? You look for an immediate family member. And if the patient is uneducated, the patient is not able to write, an X is accepted if there is a witness to his mark. So there are certain patients who cannot read, cannot write. Of course, the doctors need to explain this in layman's terms to the patient on how the surgery is going to be done, the prognosis, and so on, and X is accepted as long as there is a witness and should be secured without pressure or threat. A witness is desirable, such as the nurse, another physician, or other authorized persons. When there's an exception, when an emergency situation exists, no consent is necessary because inaction at such time may cause greater injury. Let's say, for example, the patient has had a motor vehicular accident and is unconscious, and the doctors have found out in the x-ray that he has internal bleeding in the cranium. They will no longer obtain an informed consent. They will operate on the patient immediately, or else the patient is going to die. So there are certain exceptions. Permission via telephone, cell phone is accepted, but must be signed within the next 24 hours. Now, if the patient, let's say, for example, the wallet is there, the patient is unconscious, and there are certain contacts that you can find in the patient's wallet, they need to be called immediately and to inform the immediate family members what has happened and so on, and for them to agree with regards to the surgery. But if there are no other family members that you cannot contact, they need to do this immediately without an informed consent. So what would be our physical preparation for the patient who will undergo an operation? Before surgery, we need to correct any dietary deficiency. So if the patient is malnourished, if the patient lacks protein, we give them these things. Reduce an obese person's weight, so they need to undergo exercise to reduce their weight, and diet as well. Correct any fluid and electrolyte imbalances. Restore adequate blood volume with blood transfusion if they have severe anemia, for example. Treat chronic diseases. If they have DM, cardiovascular disease, they need to be treated first before they will undergo surgery. Halt or treat any infectious process. So if they have a pre-existing infection, they need to be treated first with antibacterials, antivirals, and whatsoever. If the person is an alcoholic, treat it first with vitamin supplementation, vitamin B complex, together with IV fluids or fluids if dehydrated. Preoperative teaching, we are going to teach the patient on how to use the following: incentive spirometer, diaphragmatic breathing, coughing, splinting, turning, depending on the type of surgery that they are going to have, foot and leg exercises, and early ambulation. Now for incentive spirometer, this is encouraged to, we encourage the patient to use this for about 10 to 12 times per hour. They need to do deep inhalations in order to expand the alveoli, which will prevent atelectasis or lung collapse and other pulmonary complications later on during post-op. And there is less pain with inspiratory concentration than with expiratory concentration. We also need to teach the patient diaphragmatic breathing. So this refers to the flattening of the dome of the diaphragm during inspiration with resultant enlargement of the upper abdomen as air rushes in. During expiration, abdominal muscles contract. So we need to teach them diaphragmatic breathing. This is similar to deep breathing exercises. So we instruct the patient to inhale with a deep breath and then exhale with the abdominals contracting. So that's how we teach our patient. And in a semi-fowler's position, you need to place them in that position with your hands loose, fists. Allow them to rest lightly on the front of the lower ribs. Tell the patient to breathe out gently as fully as the ribs sink down and inward toward the midline. And instruct the patient to take a deep breath through the nose, letting the abdomen rise and the lungs fill with air. And tell the patient to hold the breath, to hold their breath by counting up to 5. And after they count 5, exhale and let out all the air through their nose and mouth. And repeat this exercise 15 times with a short rest after each group of 5. Coughing and splinting. So coughing, this promotes removal of chest secretions during the post-op. We need to teach them that. And interlace their fingers and place over the proposed incision site, which will act later on as a splint in order not to harm the incision. So, for example, there's an abdominal surgery. They need to interlace their fingers and splint it with both of their hands. They should also lean forward slightly while sitting in the bed. Breathe again using the diaphragm. I've already taught you that earlier. Inhale fully with the mouth slightly open. And let out 3 to 4 sharp hacks. This means let out 3 to 4 coughs in order for the patient's secretions to be cleared out. With the mouth wide open, take in a deep breath and quickly give again 1 to 2 strong coughs. Turning. This promotes the removal of chest secretions. So, interlace, you will do that again to protect the incision site. Lean forward, breathe using diaphragm, and inhale with the mouth slightly open. 3 to 4 sharp hacks again, and take a deep breath and quickly give 1 to 2 coughs. And when the patient will turn, for example, the abdomen is the one that has an incision. They should not twist their thorax or their trunk. If they are going to turn, they should turn their whole body like this. Advise the patient not to twist, or else the incision site will open up. That's the consequence. So teach the patient to turn with their whole body and not to twist their body. Foot and leg exercise. We teach the patient to move their legs because moving the legs improves circulation and muscle tone. Have the patient lie supine, and we instruct the patient to bend a knee and raise the foot, hold it for a few seconds, and lower it to the bed. They will repeat above about 5 times with one leg and then with the other. So you will do this alternately. And repeat the set for 5 times every 3 to 5 hours. These are range of motion exercises. Then have the patient lie on the side and exercise the legs by pretending to pedal a bicycle. For foot exercises, trace a complete circle with the great toe. We are going to teach that with the patient. Now we're going to prep the patient the evening before the surgery. So we need to prep the skin. We advise the patient to have a full bath to reduce the microorganisms from the body. Hair is going to be removed within 1 to 2 millimeters of the skin to avoid skin breakdown, and use of electric clipper is preferable. But sometimes what we use is we shave the skin prior to the surgery. And We need to prepare the GI tract as well. NPO. We advise the NPO prior to the night before the surgery. And a cleansing enema is going to be required, most especially if the patient will undergo abdominal surgery. Prep for anesthesia as well. So tell the patient to avoid alcohol or cigarette smoking 24 hours prior to the surgery because alcohol or nicotine can have an effect on the patient's anesthesia. And we need to promote rest and sleep. The patient will be given sedatives the night prior to the surgery for them to have a peaceful sleep. So, SA, American Society of Anesthesiologists Guidelines for Pre-Op Fasting. So, liquid and food intake, minimum fasting period. This is either the liquid food intake and the minimum fasting period. For clear liquids, that should be, they can drink clear liquids 2 hours prior to the surgery. Breast milk 4 hours before surgery. Non-human milk 6 hours. Light meals 6 hours prior to the surgery. Regular and heavy meals 8 hours prior to the surgery. So always remember these things. So at least 8 to 12 hours prior to surgery, the patient has already fasted. Why? This is to prevent aspirations to occur during the surgery. Because these gastric contents, they can regurgitate during the surgery. So they need to undergo fasting. Okay, now we are going to prepare the person on the day of surgery. Early morning care. We wake the patient 1 hour before the pre-op medications are going to be administered. Morning bath, mouthwash should be given. Provide a clean gown to the patient. Remove any hairpins, braids, cover the hair with cap if it is available. Remove any dentures, colored nail polish. We need to remove them with acetone. Remove the hearing aid, contact lenses, jewelry. Contact lenses can injure the eyes of the patient. Take baseline vital signs as well before giving the pre-op medication. Check the ID band, that is the protocol in order to identify the patient. Do skin prep as well. Check for any special orders such as administering an enema or an IV line. Check if the patient really did NPO. And have the patient void before pre-op medication. And we need to continue to support emotionally because at this period they have high anxiety levels. And you need to accomplish the pre-op care checklist. So this one is the example of that checklist prior to the surgery. So these are the things that we need to do. Dentures, allergies, if any, jewelry, no jewelry, routine hygiene, NPO, gown should be worn, nail polish removed, vital signs 4 hours before surgery, skin prep, and check for any labs. Now we go to the pre-op medications. Goals to aid in the administration of anesthetics. This will also help minimize respiratory tract secretions and changes in the heart rate of the patient and try to relax the patient and reduce anxiety. And what are they? We are usually giving these common pre-op meds, such as the tranquilizers. We have midazolam, diazepam, lorazepam, diphenhydramine. Remember, pam, 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 these are our sedatives, strong sedatives. Diphenhydramine can be a sedative that is an anti-allergy drug. It is an antihistamine, but it can be used as a sedative as well because they can cause drowsiness. Analgesics such as nalbuphine will be given. And anticholinergics, atropine sulfate. This will help decrease the secretions from the patient to prevent aspiration from occurring. And to reduce secretions in the stomach, proton pump inhibitors will be given, such as omeprazole or famotidine. So those drugs will decrease stomach or gastric secretions. Now, when we transport the patient to the OR, we need to adhere to the principle of maintaining the comfort and safety of the patient. To make sure that the patient is comfortable on the stretcher, a accompany or attendants to the patient's bedside for introduction and proper identification. So we need to introduce the OR attendants, the OR personnel to the patient. We need to assist in transferring the patient from the bed to the stretcher as well, and complete the chart and any pre-op checklist that we have. Make sure that the patient arrive in the OR at the proper time. So if they schedule the patient for a 10 a.m. operation, make sure that the patient is already there at 10 a.m. Patient's family, we need to direct them to the proper waiting room and tell the family that the surgeon will probably contact them immediately after the surgery. Explain the reason for long interval of waiting, such as doing anesthesia prep, skin prep, surgical procedure, and RR. If the patient will undergo, let's say, for example, open heart surgery, brain surgeries, these types of surgeries will last for a long time. They will last for more than 12 hours. Some may last for the whole day. So we will explain this to the family of the patient and tell the family what to expect post-op when they are going to see the patient. So tell them that the patient may be first unconscious, they may be disoriented once they wake up. So we need to explain these things to the family of the patient. So here's a simple illustration. You can screenshot this for further studies. And operative site identification. We need to know where the surgeon is going to perform the operation. If it's in the abdomen, which quadrant of the abdomen are they going to do the incision? So you need to know those things. You can screenshot this as well. So that's it for our part 1 regarding perioperative nursing. We will continue our discussion regarding perioperative nursing in my next video lecture. We will now go into the intraoperative and the post-operative phase. So that's it for part 1 of perioperative nursing. If you have any questions about today's lecture, please do not hesitate to contact me. I will answer your questions. You can send them as a message, and I would be more than willing to answer them for you. Again, thank you very much, and have a great weekend. Bye-bye.